In case 3, we have Mr. C, male, 60 years old, with long-standing diabetes mellitus type 2 for the past 10 years. He's been self-treating himself with metformin from different pharmacies, and the recent referral to the hospital by a pharmacist shows significantly elevated creatinine and estimated GFR of 28 ml per minute, which is suggestive of stage 4 renal failure. He has poorly controlled diabetes mellitus and is moderately anemic, with HB level at 9.5 gram per deciliter and HbA1c of 9%.
What would be your choice of anti-diabetic agents for him? What are your justifications?
According to the Malaysian CPG, anti-diabetic agents like glucagon-like peptide-1 receptor agonists and dipeptidyl peptidase 4 inhibitors, also known as GLP-1 receptor agonists and DPP-4 inhibitors respectively, are used as anti-diabetic agents in cases of renal impairment. However, GLP-1 receptor agonists should not be combined with DPP-4 inhibitors, as they affect the same class of incretins. Examples of GLP-1 receptor agonists which can be used for Mr. C include liraglutide, albiglutide, dulaglutide, and semaglutide. Alternatively, DPP-4 inhibitors such as sitagliptin and vildagliptin are chosen as they have a minimal risk of hypoglycemia and are efficacious and safe in the elderly as well as all stages of diabetic kidney disease. DPP-4 inhibitors are an oral glucose-lowering drug to be taken daily.
Sulfonylureas like dipizide and glimepiride are also drugs of choice in patients with chronic kidney disease. However, sulfonylureas are highly protein-bound, and displacement of these drugs from albumin by beta-blockers, salicylates, and warfarin can lead to hypoglycemia. If these anti-diabetic agents are not available to Mr. C, or the medications are unable to control his hypoglycemia, insulin should be given and the dose adjusted to compensate for his renal impairment.
What are other important issues that need to be addressed with him?
On top of prescribing anti-diabetic agents for Mr. C, it is also imperative to explain the risk of hypoglycemia and other side effects of the medications. Mr. C should be educated on how to handle hypoglycemia events and recognize the signs and symptoms of hypoglycemia.
Close and careful monitoring of Mr. C's blood glucose levels is essential as the dose of drugs is titrated. Therefore, it is important to ensure Mr. C is compliant to his prescription and is able to attend follow-ups. Additionally, GLP-1, RAs, DPP-4Is and other newer diabetic therapies are expensive and thus difficult to obtain. Financial support should be sought if necessary. From a pharmacological point of view, lifestyle modifications through medical nutrition therapy has been shown to improve HbA1c, blood pressure and cholesterol levels, thus managing existing diabetes and delaying complications.
Additionally, metformin must be stopped as it is contraindicated in eGFR. Less than 30 milliliters per minute oral iron supplementation can be considered to help correct his anemia. If he is overweight, a reduction of 7 to 10% body weight is targeted.